Sponsored by Sun Pharma, the makers of Illumia, tildrakizumab, ASMN. Podcast content is editorially independent of the sponsor. To learn more about Illumia, visit www.illumiapro.com.
Well, I'm Dr. Jim Rosso, a dermatologist in Las Vegas, Nevada, where I am an adjunct clinical professor at Torrey University in Nevada and direct JDR Dermatology Research, and also working with Derm Squared on Derms and Conditions podcast. So I have with me today, backed by popular demand on multiple occasions, a good friend and colleague from up in Mill Creek, Washington. Guess who it is? It's Dr. James Song, who is now celebrating 10 years. Time flies, doesn't it? Doesn't it? Frontier Dermatology as the Chief Medical Officer and Director of Clinical Research, amongst other things. So I don't want you to think he's a paper pusher behind the desk, because he sees a lot of patients and has a lot of clinical experience. So thanks for being with us today, James.
Jim, it is always such a pleasure. Whenever you ask for me to jump on your podcast, it is such an honor for me. So thank you again for having me come back.
Well, it's great to have you. So today we're going to be talking about, big surprise, psoriasis. But there's so much that has gone on with psoriasis and so much development. It's hard to believe that there's still some more things to talk about as we continue to learn more and more. But one of the things that I've noticed when we look at a variety of different mechanisms and pathways with different disease states, something that has stayed pretty central, and there are obviously some other pathways, or some other mechanisms, but has stayed pretty central to psoriasis with superb results, is interleukin-23 and interleukin-17 as two primary cytokines that have certainly have a connection driven a lot by IL-23, interleukin-23. So I want to start by asking you, where are we now in this discussion about interleukin-23?
Yeah, you're absolutely right. We got lucky with psoriasis in that it's a pretty straightforward immunological disease compared to atopic derm or HS, where you have so many different immune pathways that we have to target. But what we've seen time and time again is if you can target the IL-23 Th17 axis that you just talked about, those patients by and large are going to clear really well. And there's different strategies of how you can target that pathway. You can block a regulatory cytokine like IL-23, you could block an effector cytokine like IL-17, or you could take an intracellular approach and block some of the signaling pathways in these Th17 cells like we do with our oral therapies. But what we've learned for sure is that pathway is the relevant pathway in psoriasis, and the better you target it, the better the patients will clear.
You know, it's so interesting that you have IL-23 connected to the IL-17, and I like how you said regulatory with IL-23 and effector with IL-17. Why doesn't blocking interleukin-23, IL-23, affect hidradenitis suppurativa anywhere near like it does in psoriasis? It's because the IL-17 stimulation is by interleukin-1 beta, I believe, in HS. So it's not IL-23 that's driving HS. And these are some of the interesting nuances. But getting back to psoriasis, interleukin-23 is so important. So where are we with inhibiting interleukin-23 right now with what we have available to us?
Yeah, we currently have 3 biologics that target the IL-23, or we call it the P19 subunit of IL-23, very, very well. So we have tildrakizumab, we have risankizumab, and then we have guselkumab as well. We also have another biologic that targets a portion of IL-23. We call it the P40 subunit, and that's ustekinumab, also blocks IL-12, but also 23. And then most recently, we had an oral peptide that blocks the interleukin-23 receptor. So it does a little bit different than blocking the ligand, but all these medications, what they have in common is that they are going to block IL-23 to a certain degree.
So IL-23 is coming on the block. thinking it can push everybody around, and then James Song gets in the way and says, "Wait a minute, we're gonna we're gonna stop you here." So let's talk about differentiating, because all these therapies work, or they wouldn't be available. They all have their nuances and maybe potential pros and cons. But let's differentiate some of these agents on what they bring to the table.
Yeah, yeah. So I would say they are very similar in many ways, but there are some differences. Starting off with the half-life of these drugs, some are longer, which might allow for less frequent dosing. So tildrakizumab and risankizumab, as well as ustekinumab, are dosed every 12 weeks for the maintenance, whereas guselkumab is every 8 weeks. Also, we see differences in whether they are fully humanized or are they fully or whether they're human. So that might have differences in immunogenicity, as well as how they bind to their targets. So some have much higher binding affinity, as well as a lowered off rate. We call it the dissociation rate. And then that can also maybe have an impact on clinical efficacy. But probably the biggest difference for me is the coverage, especially when it comes to Medicare patients. We know that because tildrakizumab has to be administered by a healthcare professional or a healthcare professional proxy, it is something that we have to do in the office, but that allows us then to get this medication covered through the medical benefits, which is particularly important for our Medicare patients because they don't have to be subject to the high out-of-pocket costs that we get from prescriptions that are covered on the Part D side, opposed to the medical benefits where oftentimes it's just a copay for the office visit.
So I want to talk about that a little bit more, because the idea of having the patient in the office sounds inconvenient from that perspective, but it also assures that the patient is using that treatment. I want to get to that a little bit later, but for familiarity, let's mention the chemical names and the brand names that go with these different options, just for familiarity for a lot of our listeners, because I mean that's typically the conversation that they might be having in the office with amongst themselves and with their staff.
Yeah, sure, sure. I think only a few of us go by the generic names because we're used to giving CME talks, but you're absolutely right. So just to kind of level set here, tildrakizumab, brand name Illumia, risankizumab, brand name Skyrizi, guselkumab, brand name Tremfya, and then ustekinumab, brand name Stelara. So that's kind of how we'll talk about this, I guess, for moving forward here, Jim.
And those are the injectables, and then the oral peptide.
That's right. Yes, that's
Right.
oral peptide. So icotrokinra or icotide, which is the oral IL-23 receptor blocker. That's a peptide. Yep.
Okay, so let's talk about, are there any major differences between these that stand out in terms of the immunogenicity? Because my understanding was these agents pretty much do not have a lot of neutralizing antibody production that affects their efficacy. Am I wrong in that regard?
No,
I thought they were pretty low with all these injectables.
Jim, you're right, like usual. So yes, you're absolutely spot on. Fully human and humanized antibodies generally don't develop as many antibodies as chimeric antibodies, and even if they do, they generally don't lead to treatment loss or efficacy loss like we see with TNF inhibitors. I would say TNFs for sure, antibodies tend to be more neutralizing, but for the IL-23 class, even if you develop them, it really doesn't seem to impact the efficacy much.
I remember the conversations with infliximab that there was so much murine when you
That's
were
right.
doing the infusion, it would squeak as it went through the tubing, but a
Yeah,
great
yeah,
drug. Certainly
yeah.
but it was early on, so you didn't have
Yeah,
all that humanization done
that's
by
right.
that particular point in time, but certainly
Yeah.
where it was utilized had a lot of benefit.
And
Um,
it's interesting. That's why that methotrexate, when we add it to TNF inhibitors like infliximab, it really does seem to boost the efficacy. But for our IL-23s, methotrexate does not seem to be needed, whether we're treating it for psoriasis or psoriatic arthritis.
it doesn't add anything more to the
Yeah,
efficacy, and it's not helping get rid of neutralizing antibodies because they're not there.
that's right. That's right.
They're
Yeah,
not
that's right.
there to any
No.
significant degree. Now, what about the binding
Yeah.
affinities and things that you mentioned?
Yeah, we've seen some independent studies showing that risankizumab and guselkumab has higher binding affinity than maybe tildrakizumab or ustekinumab. at least in vitro models. That doesn't always translate to better efficacy necessarily, but there does seem to be a little bit of differences in the binding capacity. But what I can say is, all that aside, if you look at the clinical trial data and the real world experience, all of these IL-23 inhibitors seem to do very well from an efficacy and safety standpoint.
So when you're treating a patient, let's say with tildrakizumab, right?
Yeah.
And you start a patient, how long are you looking at making sure the patient gives it a try before you say, "Oh, this is kicking in," or "It's not
Yeah.
working"?
Yeah, I think it depends a little bit on the drug itself. We generally see that certain classes like IL-17 blockers, they work very quickly, so you expect to see a little bit more in a shorter amount of time. IL-23 inhibitors take a little bit longer, so I would say at least 6 months, Jim, before I decide whether this patient is a responder or not. But even during those 6 months, I would like to at least see something, even if they're not 100% clear. As long as they're directionally going in the right area, I'm happy with that. And if you looked at the tildrakizumab data, even though the primary endpoint was week 12, that's too short of a time span for tildrakizumab. You really see it continuing to improve over time, and even beyond 28 weeks, people still get further improvement. So I would say at least 6 months for me.
So 6 months when you're looking at really somewhat near that peak effect, but you'll
Yep.
typically see some change within the first few months, correct? Right?
Yeah. And the nice thing with tildrakizumab, because they are getting it administered in the office, you get to see kind of with your own eyes, how are these patients doing? And for the most part, if a patient gets at least maybe 40 to 50% improvement in that first dose, we see that that's a good predictor that they're going to get probably clear or almost clear at that 28-week mark. So that's actually a nice little tip there.
So most people are going to march up with their improvement. They're not going to have nothing and then suddenly jump up at 5 or 6
Correct.
months. I think that
Yeah,
would
and
be
if that
important.
happens, Jim, I always worry I get the wrong diagnosis. Like I should see something. It shouldn't just be nothing and then just go straight up. I mean, that's pretty rare for that to happen.
Oh, I'm not the only
Yeah.
one that gets the wrong diagnosis. James
Yeah.
Song does
Oh,
too every
happens
once in a
to.
while.
Oh, yeah. We're always learning, Jim. We're always learning.
We're
Yeah.
always learning. So, James, I'm going to have you hold there
Yeah.
for a moment. We'll get back to you and continue this conversation. But now, a word from our sponsor.
Sponsored by Sun Pharma, the makers of Illumia, tildrakizumab, ASMN. Podcast content is editorially independent of the sponsor. To learn more about Illumia, visit www.illumiapro.com.
So now we have some very good choices from the different agents that we have, IL-23, and these agents give us excellent response in the vast majority of patients with moderate to severe plaque psoriasis, which is the approval, patients that have not responded to other therapies or prescription topicals, whatever the case may be. But let's talk about the access piece, because that's one area where tildrakizumab has been a difference in terms of, number
Yeah.
one, giving it in the office and knowing the patient's getting it, as compared to seeing a patient back, let's say in 3 or 4 months, and they're telling you, "Oh, I'm doing it consistently," but maybe they're not.
Yeah.
And
Yeah.
you
Yeah.
really have no way of doing it. You have, for the record, exactly what the patient's getting. So what are the
Yeah.
pros and cons of that? Do people come in
Yeah.
for their appointments
Yes.
regularly?
Yeah, it's a great point. When you look at real world studies of what we call drug persistence or survivability, so that means how long does it take for someone to switch or stop their therapy? That's a good proxy of how well the medication, not only how well is it working, but how compliant or adherent people are. And when you look at clinical trial data, all these therapies, they seem to work very well, but that's best case scenario. Like if a patient is doing everything they're supposed to be doing, then yes, those are the results that you expect. But in the real world, it's much dirtier. It's not controlled. People have things that come up that prevent them from getting the medication. So one of the real advantages of tildrakizumab is, to your point, these patients are coming in every single visit, and you're the one, or your practice is the one that's ordering the medication, making sure it's getting covered, it's getting stored properly, and it's getting administered correctly. You're not getting a misfire. So you take a lot of these other things that can happen from visit to visit out of the patient's hands, and you're doing it yourself. And that gives you much more reliability and consistency. And I think that explains why we see, even in the real world, even though you can maybe argue one medication might be slightly more effective than another, tildrakizumab's persistence, meaning if you start tildrakizumab, the likelihood of you stopping or switching to another medication is actually better than even the other IL-23 inhibitors as well. So I think that's one real important data point there.
I'm looking at a poster that has been at some recent meetings. April Armstrong was the lead author, and there's several other authors that look at the real-world use of tildrakizumab and looking specifically as compared to other treatment classes in Medicare patients. And as you say, more of the patients are more consistent with staying on the tildrakizumab as compared to those other classes, likely for this reason, because they're coming in. And also, let's say they might be at home and be thinking, with any of the drugs, I expected more, and then they give up. But when they're in the office, yourself or your staff is having that conversation with them, maybe showing them pictures of what they were like before, or really talking them through hanging in there with the therapy. So there's that eye to eye or that face to face interaction, I would think, is so important.
Absolutely. And there's a very strong human component there. And sometimes we have to be their cheerleaders, especially if they're taking a little bit longer to respond. We have to be like, hey, hang in there. This next dose, I think, is going to give you some further improvement, but it's just going to take more time. So absolutely agree.
And there's variability, obviously, from patient to patient. There's also different personalities, people that have had it a long time. A certain increment of improvement they're very happy about, where there are some people, those kind of people, that it's hard to satisfy them with anything. They're like, oh, I expected more. So you're working with all these different personalities. But let's focus on the Medicare patient, because that's a significant population where we have difficulty in coverage. So what's special about the Medicare population where we hear so much specifically about tildrakizumab?
Yeah, I mean, historically, I think the Medicare population has been underserved. I mean, when you're commercial insured, you get access to whichever biologic or small molecule inhibitor you want. As soon as you go to Medicare, now you can't use any of those copay cards that we were receiving as a commercial patient, because that's considered to be a kickback in the eyes of the law. So even if a drug gets covered, you're subject to your normal copay, which could be a percentage of the drug cost, and that could be very, very high. Now, admittedly, in 2021, because of the Inflation Reduction Act, there were some changes that capped the out-of-pocket cost for patients. So now the most they would have to pay is about $2,100, and it is inflation adjusted. But that still can be pretty expensive for a lot of our Medicare patients, where they're just living off of Medicare and nothing, or Social Security, excuse me. The unique thing about tildrakizumab is because it has to be HCP administered, we get it covered on the medical benefits. That's Part B as in boy, not the pharmacy benefits. That's Part D as in dog. So medically benefit covered medications, you only are subject to the copay for the actual visit, which oftentimes is $0. So that's the nice thing with tildrakizumab. And you don't actually have to do a prior authorization as well. It's probably the easiest medication to get covered
for the
Medicare patients. Yeah, and not to say it's only for Medicare. For commercially insured patients too, some payers will allow you to decide, do you want it to get under the medical benefits or the prescription benefits. So you have multiple different pathways to get tildrakizumab, but it's one of the few opportunities where the practice could benefit, because they get actually a good amount of reimbursement for buying and billing. The patient gets a really good drug, and then the company that manufactures the drug, they get paid on it too, right? So you have this, I think, this great kind of ecosystem.
Everybody's happy.
It's a symbiotic relationship, where everyone benefits from it.
So James, I'm just checking my wallet. Come on, $2,100. Oh,
yeah.
I carry that around all the time. It's no problem. $2,100.
It's a lot of money.
It's a lot of money.
It could be, yeah. And honestly, even if you do it by month, that's about $160 a month. And a lot of times patients are like, I got to pick, am I going to pay for groceries? Am I going to pay for my utilities? Or am I going to pick a psoriasis drug, right? And
I'm on a drug for cholesterol. I'm on an antihypertensive. My kid is on an inhaler for asthma. There's a sequence. There's a whole bunch of copays in the family, not just one. It adds up. It adds up.
Yeah.
So are there any other differentiating factors or things we need to look out for. For example, we talk about anti-IL-17s, the issue
Yeah.
of candidiasis comes up. That does not
Yeah.
come up with inhibiting IL-23, correct, for example. But are there
Correct. Yeah.
things that come up with the anti-IL-23s that uh, we need to watch out for?
I would say one nice thing with the 23 inhibitors, they're probably the cleanest class of medication. So very, very good safety profile. We don't see the candidiasis. It actually works for IBD with higher doses. We don't see as much of the switch or the flip-flopping. Like we see the eczema develop in patients who are on IL-17 inhibitors. With IL-23 inhibitors, really, I don't see it all that often. But the one thing they don't do yet is treating the axial disease that we can see in some of our psoriatic arthritis patients. So whether they have ankylosing spondylitis, non-radiographic axSpA, or axial psoriatic arthritis, just the IL-23 class has not shown consistent efficacy in that particular domain. So that's maybe the one call out. Not to mention, it doesn't actually help with uveitis, which can also we can see in some of our psoriatic arthritis patients too. So maybe that's kind of the two areas that we still haven't seen efficacy with.
But the IBD, inflammatory bowel disease, it's not an issue with the anti-IL-23s. In
No,
fact,
yeah.
they could be helpful in many of those
Exactly.
patients, correct?
Often higher doses, but yes, it can be helpful for
Gotcha.
sure.
So how about peripheral psoriatic arthritis, not just axial?
There's this perception that the TNFs and the IL-17s are so much better than the other classes. But when you look at network meta-analyses, which are not perfect, right? I get that. It depends on who's doing the NMA. It also depends on the study. But across the board, the ACR 20, 50, and 70 scores for our IL-23 inhibitors are pretty close to or within the range of some of our IL-17 and TNF inhibitors. Actually, the only ones that really stand out is infliximab and golimumab, which are infusible IV TNF inhibitors that are weight-based. But everything else, it seems to be kind of overlapping. So I don't think you can absolutely say with certainty that you have to use a 17 or a TNF inhibitor for a psoriatic arthritis patient, because the 23s do pretty well too.
Do they affect the radiographic progression of the disease and not just the symptomatology?
That's a great question. Based on the data that we have right now, at least 2 out of the 3 don't. So tildrakizumab as well as risankizumab did not show a statistically significant difference. The challenge, though, is the placebo group did really well too. So if the placebo group does well, it's hard to show much of a statistical significance. But I would say guselkumab recently did a newer study called the APEX study, where they did look at a more enriched population where they had bony erosion at baseline, and they were able to show in that population at least that they were able to inhibit radiographic progression at a level that was statistically significant versus a placebo group, which is by and large a methotrexate group. About 60% of those patients will be on some type of DMARD or methotrexate. So,
I see. So, I mean, you have to have enough of the baseline disease to show the difference,
exactly.
as you're
Exactly.
mentioning. But we do have evidence that inhibiting IL-23 is helpful for peripheral psoriatic arthritis.
Yes, so you're not being a bad person if you use an IL-23 inhibitor for psoriatic arthritis. There are some people that would disagree with that, but I truly believe you get them on any one of these agents, you're doing better than the vast majority of our colleagues out there.
That's important to know. So, James, this has been very enlightening, but I do have a question for you. Okay. James Song is very, very busy. He starts his morning with a pile of administrative work at Frontier Dermatology because he's the chief medical officer. It sounds cool. Probably many days it's not very, very cool. And then you have a clinic with patients. You're going through everything. You have some research patients and some regular patients. And then you're preparing at the end of the day where you'd love to go home and play with your kids and hang around with your wife, getting ready for a podcast with that annoying Jim Del Rosso. and then, it's 11 o'clock at night, 10, 11 o'clock at night. And you're like, I'm tired and I'm hungry. I'm going out by yourself. Where do you go and what do you get to eat where you are in Mill Creek, Washington area?
I love that question. And as much as I love living in the Pacific Northwest, there's 2 things about it. 1, the food is not very good here, right? And I can say that as a Chicagoan. But 2, everything closes after like 8 o'clock. So there's really nowhere to go. So when I'm really hungry, I mean, I'll be honest, protein shakes, Jim. Transparent Labs, no conflict of interest here. I get 2 scoops of a Transparent Lab chocolate peanut butter protein shake. a little scoop of creatine, mix it with some almond milk, and then I just drink that and I go to sleep.
You make it at home?
Yeah,
Because you
it's just
can't
a
go
little shake.
anywhere.
Yeah, you can't go anywhere. Where am I going to go?
Where are you gonna go?
Yeah, exactly.
So
Yeah.
let's say it was 7 o'clock at night. Where would you go?
You know, I love big salads, and so there's a place called Daru Market, which is in Kirkland, Washington. No conflict of interest. They make the best salads, and I mean, I could eat salads for days and days and days. So that's my place I go to.
No wonder you look so much better than I do. I didn't know almonds could produce milk. I thought you had to be a mammal to produce milk. And at that point, we'll end the conversation, but I know we'll be talking again. Thank you so much for your time, and I'm sure I'll be seeing you at an upcoming meeting very soon.
Yeah.
Thanks a lot, James.
Jim, it's a pleasure. Thank you.
Sponsored by Sun Pharma, the makers of Illumia, tildrakizumab, ASMN. Podcast content is editorially independent of the sponsor. To learn more about Illumia, visit www.illumiapro.com.